Okay. Welcome, everyone. I'm Judith Steinberg, and I'm honored to serve as a board member for primary care for all Americans. I'm a primary care internist and infectious disease specialist, and I worked for many years in Massachusetts as a clinician and medical director in community health centers there. And then I moved to Washington and I served as the chief medical officer at the Bureau of Primary Health Care and HHS in the U.S. Department of HHS in Washington, and as a senior advisor to the Assistant Secretary for Health, where I led the HHS initiative to strengthen primary health care. So, on behalf of the board, I'm pleased to welcome you all tonight to our Teach In, Learn In Zoom session, and also to thank you for joining us. Now, with over 1,600 people from 40 states, the District of Columbia, and 350 zip codes, Primary Care for All Americans has an incredible momentum. We're building together to provide primary care to everyone in every American neighborhood and community. So thank you for your dedication and commitment to expanding access to primary care across the country. So now it's my great pleasure to introduce our moderator for this evening, Fatima Khan, and to extend my sincere thanks to all of the presenters for tonight's event. I'd also like to thank the PC for AA Zoom committee, as well as John Wright, Patty Armstrong, and Liv Verity for organizing this event. So take it away, Fatima.
Hi, everyone. I'm Fatima Khan, a family medicine resident at Jamaica Hospital Medical Center in Jamaica, Queens, New York. I want to start by thanking you all for being here tonight. By joining us, you're helping to build a movement, one that focuses on providing healthcare to people in every neighborhood and community, primary care for all Americans. If you haven't shared your community yet, please do so in the chat so we can all see who's here as we work together to build this movement. As a quick reminder, please refrain from using any professional titles. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas and commitments that will ultimately drive this movement forward. Tonight, we are here to both teach and learn from each other. We encourage you to contribute by submitting your questions in the chat throughout the session. Please stay with us until the end of the session when we will have time for a Q&A and discussion. We'll explore how you can help bring primary care to everyone in your own neighborhood and community. Now, it is my great pleasure to introduce our keynote speaker, Dr. Scott Rivkees. Scott Rivkees is a professor of practice and acting dean of education at the Brown University School of Public Health. He's a pediatric endocrinologist and physician scientist who served as Florida's state surgeon general and secretary of health from June 2019 to September 2021. As State Surgeon General, Dr. Rivkees also served as State Health Officer for the Florida Department of Health. Dr. Rivkees has been named one of America's best doctors and is a member of the American Society for Clinical Investigation, the Connecticut Academy of Science, and fellow of the American Academy for the Advancement of Science. He has held continuous NIH research funding for more than 35 years, has more than 300 publications, and currently serves as the president of the Rhode Island chapter of the American Academy of Pediatrics. At Brown University, Dr. Rivkees focuses on public health policy, leadership, training, and graduate education. He's a regular contributor to Time and The Hill about public health related issues. Take it away, Scott.
All right, thank you so much. My gosh, what an honor to be here and appear before you. So this is great. Yeah, I'm going to share about. I'm going to talk about. Let me make sure my slides come up. About some of the strategies that Florida has in place to actually boost the healthcare workforce, including primary care. We know that this is such an incredible challenge, and despite all the things that are happening in Florida, I think this is one of the areas that actually is a growing success and a potential model for others. So, as Fatima noted, I was State Surgeon General for Ron DeSantis. Before then, I was chief of pediatrics at University of Florida. And the ability to go from taking care of patients one at a time to thousands, hundreds of thousands, a state of 22 million was really appealing. And I was the state surgeon general really over the first half of the pandemic, which were really white knuckle times. Uh, as you know, Florida continues to remain in the news. And I bring this up because this has big implications for primary care with my successor, Joseph Ladapo, announcing that the state is going to try to eliminate vaccine mandates, which really can have a very chilling effect on the state. This is something we're going to have to follow. Uh, he, uh, 2 Sundays ago, he was on Jake Tapper, where he mentioned that he really had not done any kind of modeling before lifting this. Interesting interview to look at. And this is a call that we hear. It's all about personal freedom these days. I have been on media. This is a column that came out last Sunday in the Tampa Bay Times, challenging his position. And last Monday, I was on CNN. I've probably done about 30 media interviews over the past few days, and then actually had a piece that came out actually this morning about chickenpox, trying to elevate the importance of vaccination, which really is a pillar of primary care. So we'll have to see what happens here because this has huge implications for the practice of primary care, particularly in Florida, and we'll have to see what kind of spillover effect there is. Now, let's talk about graduate medical education in Florida in some of the things that they've done. And some of the information I'm showing you actually comes from reports from within Florida. And this is a report from the Office of Program and Policy and Government Accountability, which was released about a year ago. And just putting things in perspective, Florida is now the third most populous state. In 2020, ranked 25th in the nation for active physicians per capita. And Florida also is one of the growth states that we have, even though that has leveled off. So, with the population growing, and also Florida is probably one of the most medically vulnerable states there is in the country, with 21% of the population being 65 years of age and older. And when the state has done projections based upon growth, physician deficit, is noted. Now, in terms if we look at the physician workforce within Florida, providing, and this is a survey which goes out every year. In 2014, was shortly after when I moved to Florida. There were about 40,000 practicing physicians, and now 9 years later, there are about 56,000 practicing physicians. So the trajectory is going up, but it needs to be greater to account for the needs and growth in the state. But again, like many areas, there are areas where there are lots of physicians and other areas where there really are healthcare deserts. Florida is a huge state, 67 different counties. And notice that, towards the southern part of the state, Miami-Dade County, Broward County, Collier County, you see more physicians in those areas. The area in the middle of the state that's dark blue, that's Alachua County. That's where University of Florida is with a major medical center. And then we see other areas towards the Panhandle area where we see more shortages. So in addition to absolute number, other parts of this country, we have problems in terms of workforce distribution. So there have been three strategies which I'll talk about here, and that is, how do you increase the number of medical school slots? How do you increase graduate medical education training, residency positions, and then physician recruitment and retention? And as I'll show at the end, Florida has put a lot of money into these strategies, and it takes money to do this. So first, in terms of medical schools within Florida over the past 9 years, with state funding additional positions, giving additional funding towards medical schools. Enrollment has gone up by more than 300 individuals, or almost 30%, within the state. So this has been done by giving extra allocations to the medical schools to try to increase their class size. So it's gone from 976 2012 to 1,300 2 years ago, and it's even higher now. Now, one of the major things that Florida has done is, in addition to increasing the number of medical slots, is increasing the number of resident positions, both for residents but also for fellows. So when Rick Scott was governor, he actually appropriated about $83 million in recurrent funding to increase the number of residency positions. And this happened a couple of different ways. So funding was given to some of the longstanding programs in the state, but also healthcare HCA, which Rick Scott was president of before he became governor. They have a network of hospitals throughout the state, and they had not had training programs. So part of this funding initiative was to develop new residency programs in these HCA hospitals. The other thing which happens too, in addition to state funding, because the way things work with CMS, if you start new training programs you'll get funding for 5 years, and at 5 years you have a cap. And so this spurred the development of new programs, started within the state, jump-started with state funding, and then CMS funding coming in. For longstanding programs, they pretty much have been capped at the levels of the Clinton administration. So it really was through this that made a difference. And so if we look at 2012, there were about 3,000 approved positions, and by 2022, the number had more than doubled, and this happened throughout the states. In terms of the different types of programs in the investment, as I mentioned, Rick Scott put in recurring funding in the state budget, which is important, so that money is there. But during the DeSantis administration, this actually has gone up. And so Rick Scott had $80 million, and then during the DeSantis administration, it has even gone up even more substantially. And this goes for general the medical education training, but also they've targeted some areas that have been identified as a need. Psychiatry, for example, mental health, for example, also increased residency position, I mean, fellowship positions for different subspecialties. So when I was in my role, we actually would get a list of the different hospitals and positions that they wanted to advocate for. So, this is real money. So you're going from $80 million allocated for this in 2013 now to $400 million in 2024. And in terms of, some of the dollars that have gone into this, so part of this is federal, part of this is state, but largely state. So in terms of residency positions, an increase 80 million to 191 million. Support for needed specialties. This includes fellowship positions in certain areas, 10 million to 30 million. Mental health residencies at hospitals that have training programs, 480,000 to 1.3 million, and then also other funding to help start up new residency training. So, this is real money, and these are recurring dollars. So, very substantial. The other thing I want to focus on before I take questions is retention. And in Rhode Island, this is a major issue in terms of the residents who actually finish training here in Rhode Island. Uh, Rhode Island ranks 48th in terms of physician and resident retention of the states in the country. So Florida has addressed this a couple of different ways and for recruiting people from out of state. So they really have a substantial loan repayment program within the state. And this is from 23, 24, where they allocated $16 million dollars for this. So in terms of the individuals that are now funded by this, in terms of physicians, MDs, DOs, 668 that year, physicians assistants, 44, APRNs, 235, and also for nursing. So, $60 million, dollars, that's a substantial amount of funding, which is going in there, and you actually can see, and this actually has helped with physician recruitment. So in terms of if you look at physician retention within the country, Florida actually now ranks fifth, where in terms of the graduates who are there, the vast majority will stay within the state. And this involves two important pillars. So first, if you look at the individuals who stay in the state, if an individual has done medical school in Florida and residency, they're much more likely to stay than if they do residency alone. So in terms of the graph below shows the number of students retained in the dark blue and percentage of students above. And so this is something that has steadily increased. And as I'll show in the next slide, one of the big reasons for this is if you look at individuals who do a medical school in Florida and then do the residency in Florida, you have a 75% retention rate. But if people come from other states and do the residency, then it's a 42% retention rate. So because of this, increasing the number of medical school slots coupled with residency positions really results in more individuals who are staying in the state. So it's two-pronged approach. So Michael told me that I had about 10 minutes to present. So let me pause here and I'm happy to answer any questions that you might have.
Thank you so much, Scott. We really appreciate all that data and information that you had. I want to open up the floor to some questions. So if you have something that you want to ask, please feel free to add it into the chat. We'll take a look at that to get things started and really kick off. I've got a couple of questions here for you, Scott, if you're ready to go.
Of course,
All
Debbie.
right, let's do it. So you talked a lot about the legislation and what's happening. I think a big thing for people right now is sort of this bipartisan. How do we get people aligned to help them see the need both from their sort of side of the house, for a lack of better term, and how did Florida really come to understand this need for a stronger primary care workforce?
Yeah, I mean, it's not a controversial issue at all. Both the Republicans and the Democrats, hear from people in their constituency who have trouble finding care. And then also, Florida is a growth state, and, travel and tourism is their number one industry. How can you attract individuals to a state if they first can't get housing and if they can't find health care? So they recognize that this is a very important factor for the economic driver of the state. And then again, also serving the people within the state.
I I totally agree with that. So I guess the question is, was anyone opposed to this? Like, what were some of the things that maybe were the headwinds or pushback that we would have seen? And then are there so many competing priorities that and the need to build, like what gets lost in that noise of conversation and, where is there sort of agreement in pushback?
First of all, anytime you're increasing state expenditures, especially if it's recurring funding, people will always ask about that. But at least when I was there, I didn't see any pushback. And the fact that the amount of money has, nearly tripled over the past 10 years really shows the commitment to this. I mean, this is something that resonates within people in the state and resonates certainly with the elected officials, the importance of this.
Oh, absolutely. And I think you see that in the investment, both in the area and in some of the education pieces that you were talking about earlier. Now, I believe in your presentation, you were talking about how, you see this sort of hot spot of medical professionals right around where there's the university and all of that. Do you really think that primary care and public health academies and organizations should play in educating the governors about what needs to happen? Any thoughts on how we create like a big tent so we can work together under that issue?
Yeah, so there are a number of very effective organizations within Florida focusing on this. So first, the American Academy of Pediatrics. There are almost 6 million children in Florida, continue to advocate for that. And then the Florida Medical Association, is another group that helps advocate for this and actually advocate for programs to help support physicians in more rural areas. That's why I led off with that slide. It's a big state, and just like in the country, you have pockets of, excessive shortages. So there are some programs to actually incentivize individuals going into some of these more rural areas. But this is one of the challenges that we have, Patty. Most people do their training in urban centers. They like living in urban areas. And then when you move out to a rural county, it's different kind of lifestyle. So that's one of the challenges they have. To that point, I believe this year Florida is now one of the states that for international medical school graduates, many of whom are incredibly capable, when they come to the United States, we make them do the residency again before they can go out and practice. So this model where individuals, talented individuals, international medical school graduates can come to state practice under, a supervision, that's another attractive model to think about as well.
I think there's a lot of value in that. So, sort of similar to the education piece a little bit is, I'm not medical, right? I come in from sort of an nonprofit corporate mindset. So, how do we engage some of these other businesses? So, we're talking about employers, hospitals, insurance plans, pharma, community health center, medical and nursing schools, some of these other places. Do you think we can find a way to get these folks to support primary care workforce more directly?
Yeah, by directly, what do you mean?
So I think as we look at how we integrate these services together more, how do we get places more focused on the primary care services that are so critically needed?
Right. Yeah. First, I do want to say that, even though we focus on primary care, I'm a pediatric endocrinologist. I'm a subspecialist. And I also did a lot of primary care. When I was in Boston, I worked at Chelsea Health Center, which is a refugee immigrant health center. I worked at Bunker Hill Health Center in Charlestown. And primary care is important. It's critically important, but you also have to have subspecialty care. So I always say, you really need to look at all the different parts of healthcare. And the Chamber of Commerce in Florida is a very strong organization. I worked with them extraordinarily closely during the pandemic, and they realized that to have economic growth, again, to be able to attract individuals in, to be able to support their workers, you have to have health care. And so when things, appropriations passed the House, passed the Senate, signed off by the governor, which are substantial sums of money, if it's not supported by the business community, then the chance of it succeeding is much less. So again, the point you made, building a tent, and this tent is pretty broad and really has to involve the business community as well.
Absolutely. I think, this is absolutely aligned to what we are trying to say at PC4AA. No one knows that better than Michael Fine. Michael, do you have some words for us?
Okay, always. Thank you, Scott. Thanks for being with us tonight. I really, this is a national Zoom, but I really wish we had the legislature of Rhode Island and the business community of Rhode Island here listening to you. Because certainly in Rhode Island, we need to learn these lessons. As you said, we're 48th in the country for resident retention. We got a long way to go, and I think there are other states that struggle with the same challenges. And there are lots of challenges about healthcare, not just workforce. The nation now faces the largest projected increase in healthcare costs in 5 years. Cities and towns are struggling to figure out how they're going to pay for health insurance for their employees. And now, as everybody I think now knows, about 16 million Americans are projected to lose Medicaid or health insurance coverage over the next 10 years. The national primary care shortage impacts every community, and we're not expecting much leadership from Congress about these issues, as the national health policy leadership seems consumed by arguments about the effectiveness and the risks of vaccines and of the value of science itself. But interestingly, no one debates the value of primary care. So the challenge is to stop admiring the problem and start fixing it. Communities really can do this for themselves and can do what no federal government can do for them, which is to provide primary care to everyone. We now have 5 new communities in Rhode Island alone starting local work groups, with new local work groups starting up in Connecticut, in Maine, in Pennsylvania, and Virginia. So the word is, don't wait. Start a local work group in your neighborhood or town today, and we're here to help. Just let us know how and when we can help, and we will be there, because the way to build this movement is to make sure everybody across the country has primary care and to make sure that all our communities are involved.
Michael, those are, really important words. In Rhode Island, there are additional challenges here as well, and that has to do with the reimbursement rates for primary care physicians. So in Rhode Island, and which is why grateful that the legislature passed a rate review, because a physician who practices just over the border from Massachusetts, in Rhode Island, will be reimbursed 30% less than if they go to Fall River. And so this is one of the issues as well. In close New England states that are tightly packed, somebody can go 15 miles and get a substantially different reimbursement rate. And both Massachusetts, Connecticut as well. So that is one of the major issues for the state related to retention, in addition to needing more training positions as well.
Yeah, and like I said, I just sit back and I'm admiring what Florida did, increasing its investment in medical education and graduate medical education training as well. I mean, we need more medical school slots, we need more residency slots, and probably more residencies, if we're going to be able to build the workforce we need in Rhode Island. And I suspect similar things are true in other New England states. I was just up in Maine. They are looking at different options, and things they need to do to make sure that everybody has access to primary care. It is a national problem, and what you were good enough to show us is how Florida got it done, and what the rest of us have to emulate.
So, since we
Fatima,
Fatima,
you're on
you're on
mute.
mute.
Oh, okay. I hope I'm audible now. We
And I'm
heard some
off
really.
video.
Okay.
Actually,
So, thanks to everyone for making their really insightful comments. And in 2 weeks, we'll be meeting again. We encourage everyone to invite someone new to get involved in our movement. We've got two exciting events coming up, so mark your calendars. First event on September 25th at 6:30 p.m. Eastern Standard Time, we're hosting a special Teach In Learn In for Rhode Island residents. We'll be exploring an important question: how should we pay for primary care in Rhode Island? Then on September 30th at 8:30 p.m. Eastern Standard Time, we'll be gathering again on Zoom to hear from Dr. Adibe. We look forward to seeing you there. You can also register on our website, primarycareforallamericans.org, where you can also check out our local and state playbook, volunteer, and donate to support our cause. Now, I'd like to introduce Lindsay Lopez, our social media lead, who will help everyone understand how we can all use our social media to help bring primary care to everyone.
Hi, everyone. It's important to follow us on socials to grow our movement and reach as many new people as possible and many more audiences than we already have all over the country. Social media allows us to be seen in places we wouldn't normally reach, and engagement with our posts on LinkedIn, Instagram, Facebook, YouTube really mean a lot, whether that's liking, commenting, reposting, sharing. Any interaction really increases awareness of our movement. And on these social channels, we really share the latest on upcoming events, local and state wins, grassroots efforts, and anything about primary care that's happening and new and whatever you want to know. So that's whether that's in Central Falls, Rhode Island, New Bedford, Mass, Queens, New York, the movement is growing and we want to share it all. And you'll also see more clips like events like these where experts and community leaders are making real change. Join the movement, connect with like-minded people, and help us build a healthcare system that serves people, not profits. And I'll drop the links in the chat below, but follow us now and be part of this change.
Thank you, Lindsay. Thank you for joining us tonight. We appreciate every single one of you for helping to spread this movement across our nation in order to get the change you deserve. Please take a minute to complete our survey. The link is in the chat. We want to hear from you. If you would like to talk with members of the leadership team, stay on our call, and board members of Primary Care for All Americans will stay on to hear your feedback and to help us grow as a community. Thank you, everyone. See you on September 25th and September 30th.
Thank you,
Thank you so
Fatima.
much. We have some great questions in the chat, Dr. Fine. Did you see that? Oh, sorry, Michael.
I did
See?
not, but why don't you pose them?
All right. Well, I have to say, you guys sometimes are quiet in the chat, and tonight that is not the case at all. So, Pat, you've had a few questions that you've dropped in. Just Scott, are you still able to stick on for a few minutes with us? Just want to make sure you're here as we pose a few additional questions.
Yeah, I'm still here, but my video is disabled for now.
Okay, well, we will listen to your words of wisdom,
Okay.
even though we can't see you.
Yeah,
All right,
no, I
so
mean it's disabled at your end, not at my end.
oh, interesting. Well,
Yes, it's
we'll have
disabled by
John
the
Knight.
host. I guess they didn't like how my hair was parted.
Yeah, sometimes
Here I
that happens.
am.
Oh, and there you are
Okay.
again. The hair jealousy is no longer happening. So Pat, you posed a few questions on here just about as I scroll back up, how successful has Florida been in increasing the workforce and some connections to other states. Do you want to sort of go through a couple of your questions and pose them to Scott?
The more important question right now is how we can get Scott to distill the Florida experience. I mean, it's always wonderful to see something where something's actually working and being successful. But I think it could give us, if we could get the capsule of this, it could give all the different state workforces an idea of what kind of a strategy to take. I mean, over the last 15 or 20 years, I imagine there's been steady efforts by certain people, certain organizations to end up with these incredible results. I think some states don't even know where to begin, you know, as Patty was saying, who should we pull together in a state to try to put together a long-term strategy to increase funding for doctors and particularly for primary care.
we're going to be posting the video from this presentation on our website, which I hope will give state policy leaders the opportunity to look at and act on the kinds of changes Florida made. They're great examples.
Let me ask Scott specifically if there's a particular organization in Florida that kind of kept up the drumbeat over all these years in order to pull people together and have this type of success.
Yeah, Pat, that's a great question. And unfortunately, I don't know because, the initial tranche of funding, came from Rick Scott when he was governor. I'm not sure is behind that. And then a lot of the increases happened since at the legislature level. But, certainly, like I said, it's pretty broadly recognized by the legislature, by the medical communities that this is a need, and they have made that a priority.
That's what we would like to inspire all of our state work groups to do. And I think the more details we can get about how Florida has been so successful would be both inspirational as well as instructive. So thank you so much, Scott.
Yeah.
So I'm looking here at the chat again, and Larry and Catherine, I feel like your two questions sort of can be comboed up a little bit. So if either of you wants to dive in a little bit more, but I think both of you are asking about the impact of funding, Larry, you said, on policies for graduates who practice in true primary care. And then, Catherine, you also talked about the service requirements attached to that. So sort of a real focus on sort of the policy and financial surrounding the students in the medical field. Am I summarizing
Yeah,
that well?
definitely. I'm thinking especially about I'm a newly minted family doctor. Most of us historically have gone into primary care. Many of my residency cohort mates have already specialized. So thinking about how are you taking doctors you've trained and not only keeping them in state, but keeping them practicing in primary care. And some people will do that with sort of stipulations on the loan repayment programs or scholarships. Others do it different ways, and curious what Florida's strategies have been.
Yeah, as far as stipulation on loan repayment programs, I'm not aware if there are distinctions there. But, in terms of emphasis on primary care, gosh, back when I was department chairman, they actually changed the curriculum to actually have a focus on primary care. So medical student education, plays a big role within that as well. And this is something that the state tracks in terms of what proportion of physicians stay in state, which proportion go into primary care. I don't have those data to show, but again, there was a curricular change that happened. Oh my gosh, must have been about at least 10 years ago to make sure that that is included as part of medical school education in the Florida state schools.
Can I jump in just for a second and ask, sort of building on that question, did Florida do anything with scholarships that had obligations attached to them, like the old National Health Service Corps?
Yeah, I know that Rhode Island last year, had some scholarships, not recurrent funding, so that money's gone, trying to offset scholarships for that. So I don't believe that that was one of the major pillars in the strategy. You can, people go back and forth about that, but you give a scholarship to somebody going to medical school, it's a long time. You have 4 years, then you have another 3 years, so it's 7 years before you will potentially see the rewards for that. So for a new medical student, that's why personally funding residency programs, you will get more of an immediate return. Loan repayment programs, you'll get more of an immediate return as well.
So along those lines, but maybe a slight shift over into other areas of the opportunity. Margaret, who has been an amazing support of PC4AA and has a ton of knowledge about this. Margaret, would you mind coming off mute and just sort of asking your question about more the community-based side and what your thoughts are around that.
Yeah, I was wondering about any emphasis on community-based training. You mentioned that the residency slots that were created were in a hospital system, but one way of retaining people and getting people, out into those rural areas is community-based training. What are your thoughts?
Yeah, absolutely, absolutely, very, very important, and as part of these different residency positions, because I was involved at University of Florida in Gainesville, Orlando, and actually out in Pensacola, where there was an attempt to have the trainees try to go to more rural areas, sometimes rotate through federally qualified health centers as well. So again, the more exposure individuals have, the more payoff you will have in the long run. So again, if individuals just train in urban environments, that's what they're going to feel comfortable with. So, in terms of having outreach clinics, other areas, that's important. Logistically, that is a little bit more challenging, but it certainly can be done.
I think these challenges are definitely something we have talked about in different ways. I'm curious. I see some questions about, duplication. How can we take what was done so successfully in one place and then copy and paste into other states? And one thing that I'm sort of pulling out of here is the investment in infrastructure versus long-term support, right? How much do we uh, should we be investing in the infrastructure of schools and trainings and opportunities for people versus what I would sort of call this long-term support of reimbursement models or things that provide, sort of this, I'm going into this field and now I can sustain because I've got these other things in place.
Yeah, real important point. Actually, I mean, the answer is everything. So I mean, the retention rate is greatest in Florida when people go to medical school there and do the residency there. Increasing numbers of resident positions, you'll have to have more people, to help support the training of these individuals. But, that was something that most hospitals are clamoring for ways to support more resident training these days, particularly with the work hour change. So that can have an impact. And then reimbursement rates are critically important. One of the things that happened in Florida, Florida American Academy of Pediatrics chapter filed a lawsuit against the state, making sure that there is parity between Medicaid and Medicare. And that parity was approved for individuals, peds, and also for OB/GYN in primary care. It did not apply to the subspecialties. So, that is something which has made a difference. And then other states, and Florida had done this also for for women who give birth, typically sometimes Medicaid enrollment ends within 60 days, making sure that these individuals are covered for a full year. So this is also a legislative fix, which is something which is very important. So if people can pay for their health care, they will take advantage of the access availed to them. But the reimbursement rates, particularly as we see in Rhode Island, that's a really important issue.
Absolutely.
And other
Carol,
states.
yeah, Carol had asked how many of the students are from Florida to begin with.
Yeah,
Do we have?
yeah,
Yeah.
in terms of students in Florida, I believe at least so for the state medical schools, probably at least 80 to 90% of the students at Florida medical schools are Florida residents.
Okay.
And you have differential between in-state and out-of-state tuition. And if you look for a mission of a state medical school is really, to advance research, advance science, advance healthcare within the state.
Absolutely. Larry, I saw that you came off mute. I just wanted to make sure that I had captured your question well, but wanted to give you a chance to speak into that.
Thank you very much. Thank you, Scott, for your presentation. And my question for you is, we have what we know as the dean's lie. The deans report that anybody going into internal medicine, anybody going into pediatrics, anybody going into OBGYN, and anyone going into family medicine are going to primary care. And yet we know with the studies that have been done that 3 years post resident or post um, medical school, when they've completed the residency programs, there's significant differences in the numbers across specialty who actually practice true primary care. And I'm wondering, with your data, I couldn't tell, and maybe I was just missing something, but I couldn't tell uh, if there was an actual increase in the percent of students choosing true, what I call true primary care, as opposed to just choosing those various specialties. Can you comment on that?
Yeah, so when you look at the outcome data, for that, particularly with with the initial data for the increasing positions, most of those individuals were in primary care. There were some positions that were funded for subspecialty care, but most it was in primary care.
Okay, thank you.
Yeah, I also want to, again, I know this group focuses on primary care, but the subspecialty care shortage, particularly in pediatrics, is a crisis. In terms of kids with asthma, can't get pulmonologists, pediatric endocrinologists like myself. Last year's pediatric endocrinology match, there were more slots unfilled than there were slots that were filled. And this is something that we're seeing all across the board. So, so we were, in addition to having primary care challenges, we are having a dwindling, at least in pediatrics. So won't comment on internal medicine. We're having a dwindling subspecialty care workforce. And with physicians seeing more and more patients, patients becoming increasingly more complex, new therapeutics and biologicals which are out there, you really have to work together as a team in terms of primary care and subspecialty care. So lacking in one area, primary care or subspecialty care, or I'd say it the positive, both are needed really for the health of the community.
And that, when you get right down to it, is the challenge that we face and why it's going to take a social movement to fix it. I mean, at the end of the day, think of it. We got reimbursement to deal with. We got workforce to deal with, both primary care and specialty. We got workload to deal with, because certainly the workload issues are crushing, at least in the primary care arena, and I suspect in many subspecialties as well. And Scott, I don't know what you think, but I don't get the sense that anybody's kind of getting this, that anybody in Washington in particular, and often in state legislatures, and Florida being the exception apparently, but many state legislatures just don't have any kind of depth in health policy that, sort of that provides the opportunity to think about these many different challenges at once, which is why we're trying to get communities involved and, sort of build a base for change, because, legislators, when they hear people talk to them, they can't tell the difference between one and the next. But when we get communities involved and when we get, sort of policy folks who are connected to community, then I think we can make a huge difference.
Yeah, I agree. We haven't even talked about, in this backdrop, what's going to happen with HR1, where basically $1 trillion is going to come out of healthcare. It's going to have a big impact on primary care. The fact that individuals are going to have to recertify for eligibility frequently, otherwise get dropped.
Yeah.
$700 million, will come out due to that. So, so what's
16 million more uninsured.
That's right. Yeah. And so, so states are actually talking about how to deal with this by actually developing patient navigator systems that'll work with individuals to make sure that they can stay enrolled. Because once they lose their funding, they won't be able to afford primary care. And then with the issues with refugee and immigrant care, no longer be able to be Medicaid eligible. And not only that, can't be seen in federal qualified health centers, which are part of the big safety net. So what's this going to mean? That we're going to have more individuals going to emergency rooms to try to get care that they need. So again, another big picture thing. So how are states going to deal with this? And so states are going to really have to grapple with this issue and try to find some way to fund the care of these individuals. Otherwise, care will be in the emergency rooms, which is absolutely not optimal and will have an effect on emergency services.
Lots of challenges ahead. But like I said, our perspective is let's get communities involved. Communities being sometimes the locus of solution, they can work things out for themselves. Certainly they don't have all the resources that states and federal government do, but they can intervene in interesting ways, and can lead the way to push on the state and federal government in ways that advocates by themselves may not be quite as effective. We don't know how to thank you enough. That was a great talk and a great set of examples. So, our thanks, our applause. I'm so thankful that you're now in Rhode Island, and safe and able to contribute to a vigorous health policy community. It's just a joy to have you here, and we hope you'll be able to come back and help us as we work together, both in Rhode Island and around the country, to get primary care to everybody.
Thank you very much. And I see Marie Gannon's on the call. Marie, hello.
Hi, hello.
Thanks, everybody.
Thank you.
you.
Good night.
Good night.